Welcome, everyone. So good to see you all here. I know there's going to be more people joining, but I'll just take a look at that. I'm Marie Abraham. I'm the Vice President for Programming and Publications at the Institute for Patient and Family-Centered Care. And we're really excited to be joined today by Bev Johnson. She is the President and CEO of the Institute for Patient and Family-Centered Care, and she is going to bring her incredible expertise to this topic and will be sharing ideas throughout her presentation and bringing in others to share as well. So we are recording this conversation so we can share with those who registered for the recording, and we'll post it to our website as soon as it's ready. While we love seeing faces, if you prefer, you can go off camera during the presentation. Next slide, Matt. So we want to acknowledge our PFCC Connect sponsors. Thank you to Kaiser Permanente and University of Health for your support of PFCC Connect. Without your support, we really would not be able to continue these informative and inspiring informal conversations. Next slide, Matt. So let's just go over a few of our group agreements. As you know, our conversations are intended to be interactive and informative. Bev will be sharing slides to set the context and provide information to get the conversation started, but then we'll dive into the discussion portion. We just want to remind everyone of our group agreements. Be as present as possible. When we move into discussion, it would be great if you could go on video. Participate actively. We encourage you to be curious and ask questions, but also share your experiences, perspectives, and any challenges you've faced. You can either chat in your questions or ideas or raise your hand, and we will call on you. Let's share space. So we have to make sure to allow others to contribute to the conversation and not just take up a lot of time. Embrace a learning and growth mindset. All of you bring expertise, and we have a lot to learn from each other. So we're not just counting on just us, we're counting on you as well. And finally, we hope you enjoy the discussion and have fun. If you experience any technical issues, you can chat directly to Matt De Silva. Next slide. So this is what we heard from you. Thanks to all who shared questions and comments when you registered. And here are some of the issues that we learned about what you are most interested in. What are the strategies to secure and maintain funding? How can we put together a business plan to pitch to a donor? How can we use opportunities to tap into resources in our own organization? How can we learn about successes and challenges from others? What are best ways to manage and track the PFAC program for ROI? And then what are best practices so that we can get the community engaged in this work? And with that, I'm going to hand it over to Bev Johnson.
Thanks, Marie. Let's go to the next slide, Matt. Terrific. So I am just delighted to be with all of you today to talk about a topic that we all are struggling with, and that is securing funding for PFAC and PFA programs. I hope today we can really identify some of the challenges, but more importantly, what are some effective strategies? What can we do to be more successful in this arena? And I think part of it is sort of understanding the challenges. This is a really challenging time. Maybe it's because I live in the United States, but I think it's a particularly challenging time with lots of uncertainty here. But I think it is similar in other parts of the world. I think another challenge is to really convey to others the value of PFACs and PFA programs, and even patient and family-centered care. We have to, in an ongoing way, because people and leaders change, We have to keep building this understanding. Often we find that people leading these programs have limited relationships with community organizations. And that's really, really key. And I think overall relationships are the answer to so much of this work. You want to spend time and effort building your connections with key decision makers within your organization. Again, building those mutually beneficial relationships. I think we need to recognize also that there are just limited resources out there. So you really have to position yourself that you can compete and align with strategic priorities of the organization, that you bring real benefit. Next. So those are the challenges. Let's think of some key strategies to consider your program and the work you're doing. First, how are you placed in the organizational structure that assures that you have some access in some way to senior leaders? We have long urged people to make sure that they have a direct connection to quality and safety. We think best practice is when you report directly to them. That's going to be a key area for your organization. I think experience is important and is a priority also, but if you don't have that connection with quality and safety, I think you will be more vulnerable. Another is that you have those relationships with different kinds of departments. The volunteer office can be really, really helpful to you. They have community connections, and they have people who choose to volunteer because of their gratitude to the hospital. Some of those people are connected to community leadership positions, may have family foundations, but the relationships with the volunteer office can be helpful in so many ways. And it's a first step in terms of community engagement. A few years ago, many of these departments in hospitals and health systems were called diversity, equity, and inclusion. This has changed somewhat in recent years in the United States, and there are other departments that want to build partnerships with the broad communities that you serve across a range of populations. So build a relationship with that department, have coffee with them, invite them to come just for learning to see what a PFAC does. And then certainly research that division or department within your organization. Often they have funding for research partners, and you want to get to know them, not just at a specific grant, but you've built relationships so when a grant comes about, you could work together. And one of you said in the questions you submitted that you hadn't knocked on the door of the hospital foundation or philanthropy department. I suggest you knock on that door. And, you might be intimidated, but just say, I love what I do. I think it's important. I'd love to know more about what you do. Let's go have coffee. And that's a beginning first step. And it's not really competing with other grants coming into, gifts grants coming into the hospital. Some people want to give to this kind of thing, others like machines, physical spaces. Others might be really interested in safety and the experience of care. So you're helping them and they're helping you. Next. I mentioned about relationships, and I think our friends at Anne Arundel Medical Center in Annapolis have done a really smart thing in that they have always included their senior executives in their hospital-wide monthly PFAC meetings. So the president, the chief nurse and the chief medical officer attend on a regular basis. That means they know advisors, they know the priorities, and so they are a part of it, and they can work together on the PFAC strategic plan and bring information to work on the hospital and health system strategic plan. Another connection here, I chaired strategic planning many years ago, decades ago, I guess, for a children's hospital as a trustee. And it was an opportunity to bring in new voices and new relationships. I knew so little then. I look back on it now. But it was, again, all about relationships and ensuring that these voices are part of the overall strategic planning. Next, Matt. Some of you asked about grants, and this is just one idea. And again, the Development Office Philanthropy could help you identify some grants that might be appropriate for you all. But this is not for the children's hospitals, but for adult hospitals. Perhaps a priority is that you want to improve elder care. And there has been a long-standing, really excellent program called age-friendly health system improvement work, funded by the Hartford Foundation. The Institute for Healthcare Improvement has a lot of information. You could go directly to the John Hartford Foundation, but they also fund the work, and they want advisors to be part of this improvement. So maybe it's your emergency room that you want to have more elder friendly, or maybe it's across the board, but build those relationships, and this might be a funding source. Next, please. I can't overemphasize the importance of annual reports. We have a section on our website that I hope you will go and visit. Lots of examples. And if you haven't sent us your most recent one, we'd love to add it to this collection. So you can get lots of ideas, but you can use your annual report as something you hold in your hands that you can give to someone as you build relationships. It can be sent to really all the senior leaders, the board of trustees, the people that control the operating budgets, because I think most of you are basically funded through operations. So you need to keep that, and you need to compete for that, but then you need to have these reports. Caroline Longchamp from the Medical University of South Carolina has developed these reports for a number of years, and I asked her to join today to share some thoughts about her report and the development of relationships with senior leaders. Caroline, are you there in South Carolina today?
I am. Hey, Bev.
Welcome.
Thank you. Yeah, I think, the first year I created an annual report was the first year I had help from an intern who was really passionate about patient and family center care. And my reasoning was that we are a non-revenue producing department. Um, I learned from Bev and others that it was important to report up through quality and safety. And when we first established my role, I didn't understand the why, but I knew that people who were smarter than me said it was important, so I did it. And I don't take that for granted every year because as the hospital system changes and we get new leaders, there's always the potential for us to get moved to another department. So our annual report is quite purposefully very heavy in quality and safety. One, because I report to the CQO, but also because we want to maintain the integrity of the work that we do as it relates to outcomes and not patient satisfaction scores or other initiatives. And so the annual report serves as a way to sort of market what we do, to brag about what we do, but it also serves as a kind of a history book for those of us in the department and for the quality and safety team to remind folks about what we've done year after year and how we've gotten better at doing some things and maybe where we're kind of we're regressing in some areas. That happens too. And so we need to say, hey, look, we used to do this and somehow we've gotten away from it. But that alignment with quality and safety has been so very, very important to us. And the annual report is the best way I know how, because we can distribute it broadly to senior leadership, to the president's office, to the CEO's office, to make sure that they know what we're up to.
That's great, Caroline. Share a little bit about your recent conversations with the leadership in the Children's Hospital that really started long before COVID.
Yeah, there was a lot of work. The chief of the Women's and Children's Hospital came to me and said, we're not really doing what we used to do. We're not doing all the things that we did that got us into this beautiful new building that we built with 27 family members who sat at tables with architects and builders and nurses and physicians to create this incredible space for patients across the state of South Carolina. We're just not doing it. COVID is part of the reason. A whole new workforce in that building, but we stopped talking about it the way we used to talk about it. And how do we reset? And it took a couple of years, but he finally came to me and said, you know what, I'm done talking about it, and I'm going to do it, and I'm going to utilize philanthropy funds to do it. And Mara Hassenfuss is joining the webinar today as well. She is our new Patient and Family Center Care Manager for the Children's Hospital and Women's Pavilion. She is not new to MUSC. She actually comes from our patient engagement team. And I know that there are those of us on the call we're called different things, but sometimes, and those titles matter to me. Again, I learned this from Bev and others at the Institute, but we maintain the integrity of the title patient and family center care. It's important. Mara's been here for 12 years. She knows the system. She understands patient and family center care. Zero training as it relates to her coming on board, but she's in a new area. And so what she's been doing the last few weeks is establishing and building relationships, building trust with the care team members, and helping them understand why she's here and how she can support the good work that they're already doing. But we think that we're going to be able to move the needle very quickly just in that first year. So we want to capture things, and this is included in our annual report. One of the new things I started capturing this year was consultations, and I labeled them consultations because there are a lot of work that I do that I wasn't recording. So if an OBGYN reaches out and says, hey, we're having this ethics meeting with our residents because there's a lot of distress for our young residents about patients who may not want to jump on board with a certain care plan, and who is my responsibility to, the mom or the baby. And so including patient and family center care in that conversation gives us visibility. It allows us to invite patient and family advisors to join that conversation. And we need to shout out about that. And because of that, now other folks are reaching out for consultations or advice or small meetings to talk about things like family presence and visitation, and how we move the needle there.
Great. Thank you. That's wonderful. Lots to learn from your good work there. Next slide, please. I think Caroline has illustrated beautifully different ways that you can use your annual report. And it really is, you can open doors with it, or you can follow through, you can show your appreciation. So and we have lots of samples that you could look at to help develop your next report. Next slide, please, Matt. Another thing besides an annual report is an annual meeting. And I don't know any place that has done more of them and more exciting ones than Wellstar MCG in Augusta, Georgia. This past spring, they held their 19th annual meeting, and they have been a great success from the very beginning. They celebrate accomplishments of the PFAC and PFA program, the partnerships with leaders and staff. They set the stage, often sharing their strategic plan for the next year. In many ways, their education, but in a fun, celebratory way. So there are a number of places that do these really well. At MCG, next slide, please. I love the cover. Go back one so we can, I love the cover of this. Each one has a theme and a guest speaker. Seeds of Change, Cultivating What Matters Most. And just an idea for thinking positively of the contributions of PFCC, PFACs, and PFA programs. Next slide, Matt. Sorry to go backwards. They use it for presenting awards, and I know a number of you do this, and I highly recommend it because it's another way to educate, to celebrate, and you could even perhaps find donors for different awards. They have long honored the wonderful memory and leadership of Pat Sadamka. It's a great way to show senior leaders what you can do to be the effective executive champion for PFCC. But they have other awards, and I think even next year they're going to have more awards. And recently, next slide, Julie Moretz from MCG. I hope she may be in her car driving home from the airport. Julie, are you there?
I am here, Bev. Hello.
Wonderful.
We made it in. Absolutely. We flew all night, but just got in about 30 minutes ago.
Great. Well, tell us about this award that you created and then how you've developed it this last 2 years.
Sure. So E3, every person, every encounter, every time. We really wanted to have an award aside from the PFCC awards that Bev just showed and shared with you. And those are important. Those are annual awards. Those, are coveted awards from our whole organization. But our E3s, that's something that anyone can be recognized for going above and beyond. And this is the criteria. It is our patient and family centered principles. We look at that. We have 5 team members who review these that come in randomly, and not everybody is a recipient. And I say that because it might be a great thing that this person is nice, and that's great, but we want to make sure it's deeper than this, that it's really meaningful. So sometimes we suggest that the department recognize their team member within their department. But when we do our E3s, we do have senior leadership who participate in this, and it's just a great opportunity to showcase people that otherwise we wouldn't really know all these great works. And this, even Bev, I haven't even shared this with you, these E3s also turn into connect to purpose stories. Our president starts off every meeting, whether it's a corporate meeting or whether it's our management meeting of all of our 300 leaders, he always starts off with it doesn't have to be an E3, but it's a connect to purpose story. And we pull from our E3s. So wanted to share this. It's just, we give out little E3 pens, and we have a silver, we have gold, and we have platinum. And we just gave out a platinum E3 to an EVS worker, environmental services worker, just last week. And it was just amazing because she just goes above and beyond in connecting with the patient, more so than making sure that the room is clean and safe. She really delves deep into working with our patients.
That's wonderful, Julie. And I think one of the things that's really key here, that when you talk about the connected to purpose or the E3 awards, you're taking it back to PFCC core concepts.
Absolutely.
And a lot of people don't do that. They do. It's a great mission moment, but it doesn't reinforce respect and dignity, information sharing, participation and collaboration, and some aspect of those things. Well, since we're talking about community relationships, Matt, the next slide.
So Bev and I have talked about this a lot, but right after COVID, some of you may have heard of the Augusta National Golf Club, which is just happens to be just right down the street from me. But we've had a long-standing relationship with the Augusta National, just great community partners. But right after COVID, they came to us and they wanted to honor healthcare heroes. So my president came to me and said, "Hey, we want to select 12 of our E3 recipients, but not only the recipients, but those who nominated them." So it was 12 recipients and the 12 of those who nominated them, which was just great because you can't have good recipients unless you have those who understand patient and family center care and understand what the nominations really mean. So it was a great celebration. The first couple, a lot of the leaders from Augusta National came to the hospital and we shared the stories, and they were just blown away because they just didn't know the depth of what our team members did, and again, it was beyond nurses and physicians. We did have some of those as well, but it was our security folks who would go, stay in a room with an autistic patient and really connected with this autistic patient. So it was really deep stories, and they were just so blown away with that. So they've done this every year since then.
So first of all, I need to let you all know that we know that not every one of you have the Augusta National Golf Club in your community, but you have other organizations similar that are beloved by the community and that you can build this. And this is another way to build connections with leaders. So just a wonderful example, Julie. Thank you so much for all that you do. Next slide, Matt. So some of you asked in your questions about how do you develop a business plan? And some of you were saying, how do you make it develop a business plan for a funder? It could be an outside funder. It could be just competing for your operations funds. I think I look at it in a sort of a doable, practical way that what makes sense? How can you support and grow your program to grow your impact? What do you need to communicate? And in the slides, there are going to be some links to nonprofit business plans. I think they have language that's more relevant for you, but I just pulled some of the things that I think are basic to developing a business plan. You want to have a thought about what really is the mission and vision for PFCC and your PFAC and PFA program. That what do you really want to accomplish in the future? What are you doing on a regular basis so people really know that? Having specific strategic goals and objectives. I know many of you who have like a 3-year plan and then you make progress each year on that. Or you may have really an annual plan. But again, we talked about how to involve not only your advisors, but your executive champions for the PFACs and other leaders. So you're developing this collaboratively. And certainly it's another time to partner with community leaders as well. We talked about letting in the business plan show where you are in the organizational chart. It's great if you can show a visual of that. And certainly who are your key staff and their roles and the reporting relationships. People need to see where you are in the context of a hospital and a health system. Then be sure to, and some of these you can pull right from your annual report, but you want to describe and quantify the hours and activities of advisors and councils so that they've got a substantial understanding of what you do. And any current funding or contributions from the community, from families, from grants, corporations. I think back to early work when the Family Resource Center was started before it was totally funded by a family foundation at Children's Hospital of Philadelphia. They did really family coffees. And they partnered with Wawa. And not all of you know what Wawa is, but it's a little mainly fast food coffee place in the community. And they were looking as a small business for visibility. And so they paid for coffee. Well, that led to people understanding and seeing the value of those family conversations, the need for further information and education, and then later a large family foundation gift. And then in your business plan, you've shown what your current funding is, and now you list what you're requesting from various sources to build your budget for 1, 2, or 3 years out. Next slide. So there's a template for that, but I think it's really important in a business plan and in your annual report to convey how PFCC and the PFAC and PFA program contribute to your organization's strategic goals and priorities. And I can see Dawn right on the top of my screen here, and I think of Dawn Niebring at Cincinnati Children's as a wonderful strategic thinker who really has embedded their work in the quality improvement, excellent quality improvement at Cincinnati Children's. Can you share a little bit of your strategic thinking in all of this, Dawn?
Of course, and Bev, thanks for just saying those words. I hope they are true, at least sometimes. And I appreciate the grace with which you asked your question, which wasn't show me your business plan, because I didn't have one. So just for you all on the call. But the thing that I'm resonating with that Bev mentioned earlier is grow your program to grow your impact. And our story at Cincinnati Children's is starting with a more, we've had a PFAC since the early 2000s. It was super early engagement by our senior leaders, but as Bev said, senior leaders change and priorities change and things start to get taken for granted, and folks get comfortable. And so we always had just one dedicated employee to support our system level patient family. Actually, it's mostly just a family advisory council. And then we had our child life team support a patient advisory council. And we were so good at that. We spent, 20 years doing that. Then though, paying attention, recognizing that a single person can't really grow. Our system grew at like a rate of 10% every year for a decade. And so we got way bigger than what one person could do, but we didn't have a plan for what to do next in order to ensure we had the program we needed to meet the moment. And how we learned that was from internally, our community and population health folks coming to us to say, help us understand how you have a representative advisory council. We didn't. And so we had to really look kind of vulnerably at some of our original ways we did business and the assumptions we made. And we had to shift some of those in order to be different than we were for 20 years. So what happened is we partnered with our folks who are very engaged in our community and population health and said, help, look at us, see what we do and help us do it differently. Where are our vulnerabilities to not being able to change and meet the moment to have a representative gathering of what we now call patient and family partners. And so then we did. And what we learned by partnering with our families who were not in our original set of families on our advisory council was that one of our assumptions we were making is that people had the time just to give to us, to show up when we needed them to do our work with us. And that family partner was like, look, I am making choices all the time about how I spend my time. And you all get paid to do this. What you give me a Kroger gift card, that doesn't give me the flexibility I need to actually use the money the way I need to use it. It was actually coming up on the holiday season. And that challenge, which is an old way we thought, right, is has to be a volunteer. We can provide gift cards for extra effort or whatever, made me go, we cannot become what the organization needs us to become until we describe how inequitable it is to have a system where we bring our staff and our leaders to a table and expect our families and patients to join without an opportunity to honor their time similarly with money. So we had to build a case for that, and we had to go through that. I think that is the game changer from that, and it is what our program needed to both have representative participation from our patients and families across our system, as well as grow. So when we did that, and we made the case, we have paperwork on that, that also begat my opportunity to, for what I controlled, to shift who does what. So I had FTEs, we added an FTE, and then we pulled an FTE from another part of the system that had a role similar. So now we are centralized. Doing that begat the opportunity to do more. Is that kind of what you're looking for?
Oh, absolutely. That is terrific. And, you've said several very wise things. First, grow your program to grow your impact. You're not just trying to grow it for the sake of getting bigger. You're growing it to fulfill a real need. And that's what you jokingly said, you didn't have a business plan, but you were able to build the case to say, we're not really fully representing the community because we need people need compensation. And I know this group is going to want to talk more about compensation. And maybe that's a future, we've talked about it in the past, but that is a future conversation that we ought to have about how do you do that? How do you make it work? And how do you raise dollars to make it work? So that is really wonderful. And you also added a department that I didn't say it by name, which I think is really a good department to have knock on the door, and that's population health, because they are reaching out broadly to the community, and you can build on those relationships. So thank you, Dawn, so much. But think about when you are doing your business plan, your annual report, your annual meetings, how are you helping to build on the strategic priorities, the organizational goals of the organization? So as you contribute to them, you're going to be perceived as being more meaningful, and people are going to want to support your efforts. Years ago, I had a wonderful chance in Alberta, in Calgary, to work with Joanne Ganton. And she worked with so many advisors in two different major hospitals in Calgary, to have them very involved, not just in the design, but long-term. And I think she's joining us today also from Calgary. Are you there from far away?
I am. Good morning, or good afternoon, perhaps, for some.
Tell us, Joanne, you have talked about never letting a good opportunity go by, and tell a little bit about how you were able to grow the program from facility design to much more impact.
Yeah, well, I learned very early on from a very wise Beverly Johnson to really take advantage of what we call catalyst events. Look for those catalyst events in your organization's business planning and priorities. It might be a new facility or a clinic redesign. It might be a restructure, like we like to have very often in our province. It might be just a change in leadership. But look for some catalyzing events that really open the door to conversations to say, where does the voice of patients and families fit in? And where does patient and family-centered care really fit into the conversation very early on in those planning conversations? I was very, very fortunate to be part of both the Children's Hospital planning project here in Calgary as a parent, but then later on as a staff member, got to lead the planning to embed the patient and family-centered care practices and really build a program for the new, really one of the first hospitals in Canada, where we were able to introduce family presence and so many of the other patient family-centered care practices. And it was patient and family-centered care was always touted as one of the pillars of this new hospital. I think the others were like clinical excellence, wellness, environmental stewardship, and patient and family-centered care. And when it came time to move from a planning and design project, and we certainly had many, many patient and family advisors and an advisory team that worked closely with the architects and the designers and all the clinical planners. But when it came time to move into operations of that brand new hospital, we had to pitch our budget to our vice presidents and to our leaders. And, I really recall a very important conversation where, the leader said, you have one position to lead patient and family-centered care in this new facility. That's what we've budgeted. And I said, well, I can work really, really hard, and I will work very, very hard for you, but I cannot do this alone. And I use the phrase, is patient and family-centered care a marketing slogan, or are you serious about building it into the strategy of the hospital? And what exactly does that look like? And that means, putting in place some tangible pieces. And we were able to build a budget, an operational budget for a staff to lead the work and to build it into the facility. And ultimately, everyone on this call, I'm sure, knows it takes a lot of hard work to put in place, create new policies, and to roll them out with all the clinical teams and do all that education. And you need a team of people, of really strong and committed people to do that. And by building it in, so it wasn't just a marketing slogan anymore, it was really going to be part of the operations. And the other key line that I think got the leader's attention was, would you build a patient safety program or say patient safety is one of your priorities and not allocate any resources to it? And there was a nice, long, quiet pause. So how would you like to build a patient and family-centered care program, but not allocate any resources to it? So, you have to be really strategic, but really pointed with those conversations sometimes to move the bar forward.
Oh, Joanne, thank you so much. That, again, really wise comments from just wonderful experience and success and helping people really see what's possible and how it needs to be supported. So I think the more you can relate what you're doing to your hospital or health system or clinic may have different priorities, but you need to know them and then align the efforts and never miss an opportunity to think how you might have some impact. Next slide. So in conclusion, I wanted to share this slide and this thought from years, I have to say now decades ago, from a CEO who was self-described as a numbers person. And we didn't get along perfectly at the beginning at all. And he said, you deal with the soft stuff and I deal with the real important stuff. And so fortunately, the health system had wonderful leaders who just kept working on it and kept showing him the benefit of PFCC and partnering significantly with patients and families. And I will give full credit to this leader who was able to turn around and say, I now think of patient and family-centered care is the most powerful business transformational tool I have. It impacts every single one of my business metrics. And if you look at that list of finances, quality, safety, satisfaction, and market share, and I think it works across the board, even if you have a very different healthcare system than we have in the United States. So I hope you've gotten a few ideas. I know all of you have so much to contribute. I've seen in the chat wonderful ideas about luncheons to celebrate this good work and a gala. And that's just so important to do. It builds relationships. It means you also have fun while you're doing it. That can help. So I'm going to turn it back, and I think Marie and I will take questions and discussion.
Yep. We don't have that much time, but yes.
Any folks want to? Barbara?
Barbara's got her hand up.
Great.
Yeah, thank you very much. This has been so educational. I so appreciate it. So you mentioned a couple of things that I just wanted to share the research that I've done over the years. I did most of it last year. So one of them was about where the location is of the PFAC, and I'm just looking at my Excel spreadsheet on my other monitor, and 54% are located under patient experience, and there's much less that are located under the quality. But I'm finding that actually it's 11%, 23% are located under quality and safety. So I know of one organization, a large organization, that's moving their PFACs under quality, which is really great. And I agree that's where it should be. In terms of the report, what I found in my research was that 54% have an annual report about the PFAC, but 25% have a quarterly report as well. And some have a monthly, 4% have a monthly report. And what I found in the research is that there's a direct relationship between the visibility and the amount of content that a PFAC gets. So I'm encouraging PFACs that I'm working with to produce a quarterly report so that their good work is out there on a quarterly basis and not just annually. And of course, the most important thing that I'm always harping on is prove the value of the PFAC by measuring, and especially the financials, because proving their value will result in paying PFAs for their work. And thank you, Bev and Marie, for all your good work too.
So Barbara, maybe put your website in if it's not there, in the chat so people have it, because they might be very interested in your articles or data and the work that you're doing. Thank you.
And it's all located there. Thank you, Bev.
Great. Anjali, nice to see you on this call.
Hi. Sorry, I am here. I just thank you so much for this call, and I'm not sure if there's going to be recording. Yes, maybe.
Yes.
Yeah, so I will definitely revisit parts that I want to go back to. But I have to thank you, to the IPFCC team, because your pinwheel newsletters, I had briefly told Marie, I saw a brief posting, I happened to look, and I'm so glad I did, because there was a family as faculty training opportunity that Holland Bloorview had offered. And so just for context really quick, I manage our family advisory council at Children's Hospital at Montefiore in the Bronx, New York. But it was such a great specific niche opportunity that I didn't want to miss. But then I was at the point of, well, how, because I'm an external person, how would I pay for it? And I didn't want to just give in to me just pulling it out of my pocket. So I did do some research, and I tried to just do whatever I could do, reach out to people I knew. And I knew that turnaround time was so short, but I say all this to say that I did strengthen the partnership with our Office of Development and Alumni Relations here they take care of funding, and Bev had also recommended this as well. Like I had been in touch with the lady, but now we have somewhat periodic standing meetings so that I can
Wonderful.
stay in her pocket and she knows of what we're doing. And so anyway, long story short, she was miraculously able in like 2 days to reach out to a parent of one of the children here. And that lady, I wrote a business plan, submitted it, and it all happened. And then I got the funding, and I
Oh,
was in disbelief because it was such a short turnaround time. But actually, one of the doctors here had told me, she's like, go with a business plan. She said, if you don't have specifics, the numbers, why you're going to use it, what you're going to use it for, you're not going to, you might not get that far. So I think all those pieces really matter.
great.
But thank you guys to you guys. So
That's terrific. And Anjali, who's in the Bronx at Children's Hospital at Montefiore, that's just a wonderful example. And another thing in terms of building these partnerships, by working and partnering with the diversity of the community you serve, you're going to build the capacity and the skills and the experience of your advisors. There's a real benefit to this work for them too, and can make it very rewarding. So kudos for that. We've got just a little more time. Are there other comments, questions, or success stories like that wonderful one? I see that some of you've shared how you do payment to advisors. I haven't looked at it in detail, but $20 to $25 an hour have been, and I know some people decide and say, I don't need this, I want to do this as a volunteer, and others can't do that. And so you have the flexibility. Jonathan, I see your hand up.
Had to find the mute button. Yeah, today was great. Thank you so much, Bev, for this. I think one of the things that you touched on today that really is so important for us as an organization, and one of the things we have pushed is annual reports for all of our advisory councils, and making so we have 80 across our enterprise, and making certain
for everyone, do they all know you're from Kaiser? So
yeah,
a larger system.
Yeah. But making certain that each advisory council completes an annual report, and then having a very specific path for submission of those annual reports. And then we do an enterprise annual report, which this year, like as I was looking at it, was really excited because I think coming back and showing value is so important to allowing growth, to allowing funding, to all of these things. So I can't hit on an annual report enough, and the importance of that.
Great. Thanks for that. And Ernie, I think you might be the last person.
You're on mute.
I think, so I apologize. I think we're in the process of creating the first hospital-wide PFAC. And this discussion has come up because right now our volunteers are people who can afford out of their own pocket to pay for volunteering. And one of our big discussions is how do we, with our patient census, have our PFACs represent our people from all over our patient census and work out a system so they're not paying us to volunteer. We don't necessarily pay them for their volunteer time, but we make sure it's not out of pocket costs, and it covers so that they're breaking even at best. I mean, or I hear some people are paying volunteers. That's pretty nice, but in North Carolina, that might be a harder thing. But how can we build a system where we at least make sure volunteers, that anyone can volunteer and there'll be no economic disadvantage to it? I think is the best question.
And I think just in the short time, I think you need to make the case how important the diversity of ideas are. That I don't know where you are in North Carolina, whether you're in a rural community or urban, but to be able to, not everyone can afford, and so you qualify, you limit the value of the comments that you're going to receive. So the more you can begin to say, we want to have an impact on things that cost your hospital money. When we make mistakes, when people go home and are not adequately prepared to care for themselves in the community, I think if we partner with patients and families, we'll know how to improve our safety practices of how to prepare people in ways that work for them. And they become partners in this. But it takes a little bit of engagement, a little bit of support and upfront funding. So I think to talk to community leaders, and I don't know if you're in a small rural hospital, in that case, I know there are a number of people on this call from there that you want to, again, build relationships and find organizational and family donors to just get you started, and then you can show this makes a difference.
I'm a quick thing. I'm from UNC Chapel Hill, where it's a central hospital, but we have lots of regional hospitals. And they're forming, I'm part of a group forming the first PFAC for UNC Chapel Hill, which will cover all the hospital, not little separate departments. And so, yes, I appreciate your words, and that's why we're trying to set the standard to begin with. So I really appreciate anybody's help, advice, tricks they can come up with. We have to say patient-based census. That's the word we have to use. So that's the politically accepted word.
Well, I hope you can listen to some of the folks that were on this call today that shared their thoughts, and maybe you can bring them together, show the video and talk about some of the pieces of what they've done. But I'm happy to follow up with a conversation. I care a lot about North Carolina, and I'm about to go to the Raleigh-Durham Airport in 20 minutes. So I'm just visiting, but on my way back home. So thank you to everybody. I want to turn it back to Marie.
Thank you.
Okay, so there were a number of resources shared today, and these two slides, 19 and 20, will be presenting them. You'll receive a copy, PDF copy of the slides from today's session, so you'll be able to access these resources. Next slide. So I think Bev mentioned the templates for nonprofits, and it's right here. And then next slide. So we so appreciate our Pinwheel sponsors. And if you would like to support us, you can become a Pinwheel sponsor, and you can find more information about how to do that here at this at this email. At this website. And then if you need some assistance, you can ask Liz Hansen if you need more assistance. And her email is right there. Next slide. So many of you are members of our free online learning community, PFCC Connect. If you're not a member yet, we really encourage you to register so you can access great information and resources about patient and family-centered care, post questions, learn from others, share great ideas and resources, and continue these conversations. Next slide, Matt. So your feedback is important, so we ask you to complete the survey as we use the results to give us ideas to improve our conversations and determine what topics are of high interest to you. You can use the link or the QR code. So our next informal conversation will be held later in August 2026, and the topic and date will be determined. If you have ideas, please let us know on the evaluation survey. That would be really helpful. The recording, slides, and chat log will be posted on the PFCC Connect site by early next week. So you can email me directly if you have any resources or links to relevant sites. My email address is mabraham@ipfcc.org. And as you probably know, you can continue the discussion in PFCC Connect.